Welcome back everybody, David here again with Med School Bootcamp. So in this first video, we're going to talk about pre-renal acute kidney injury. If you recall from our last video, we talked about how you can have three main types of acute kidney injury. You can have pre-renal causes, which occur before the kidney. You can have intrarenal causes, which occur kind of within the kidney. And you can have post-renal causes, which occur after the kidney, in the ureters or the bladder. And so with pre-renal AKI, we're really talking about things that are going to occur before the kidney or things that are going to stop blood flow from actually reaching the kidney. So when we consider the pathophysiology here, we really are going to think about two key things. One is a decreased cardiac output or decreased CO, or patients can have a decreased effective circulating volume. And the reason these two things are so important is because they both lead to a similar thing, which is to have a decreased renal blood flow and ultimately a decrease in the GFR. And recall, from a definition perspective, the cardiac output is the volume of blood that the heart pumps through the circulatory system within a minute. And the effective circulating volume is really talking about the amount of fluid in the system can actually perfuse the organs. So if we have a decrease in either one of these, we're getting less fluid to our kidneys, and this can cause some problems. If we get less fluid to the kidneys, this is what explains the decrease in renal blood flow. If less fluid is ultimately coming in through the glomerulus and making its way around, less of it actually gets filtered in Bowman's capsule, and that is why we get a decrease in the GFR. Now, remember, what happens when the kidneys sense low volume status or low sodium status? They get activation of the renin-angiotensin-aldosterone system. And that's our next step. So it's the decreased renal blood flow and decreased GFR that actually triggers the activation of the renin-angiotensin-aldosterone system. And recall from previous videos, what's the primary mechanism by which this acts in the body? It's primarily going to lead to an increased release of a molecule called aldosterone. And recall, through various mechanisms, aldosterone is going to cause an increased reabsorption of sodium in the kidneys, in the tubules. Remember, when sodium is reabsorbed, what's going to happen? Water is going to follow. So that increased reabsorption of sodium is going to lead to an increased reabsorption of water. And this explains our next step in a pathway, which is that we have a decrease in urinary sodium and H2O levels, and we have an overall increase in urine osmolality. Again, we're taking out some substances. We're taking out the sodium, which is taking out the water. Overall, this creates for a more concentrated tubule, which we call an increased urine osmolality. So that's the pathophysiology here. The kidneys sense less fluid for a variety of reasons, which we'll talk about in a second. With the sensation of less fluid, we get activation of the RAS system. This is going to reabsorb sodium from the kidneys, ultimately leading to more water reabsorption as well. And recall, just a quick review of our terminology. When we say reabsorb, we're saying that we're taking substances from the tubule, from the lumen inside of here, and we're pulling it back into the body. This is different than saying we secrete substances, which is where we do the opposite. We take things in the body and put them into the tubule, and ultimately excreting substances is when we actually have them leave the body through the urinary tract. Next, I want to talk about some of the common etiologies that can lead to a pre-renal AKI. The first of which is hypotension, with the two kind of classic ones they ask about being heart failure and cirrhosis. So think about what we said here. We said that a pre-renal AKI is typically due to the kidneys getting less perfusion or less blood flow than they would expect to get. This ultimately leads to damage in the kidney itself. So in cases like hypotension, right, a heart failure, we know that the problem is with the heart contracting. There's enough volume in the body, right? But the heart is not pumping that volume forward. So if the heart is not pumping that volume forward, then the kidneys don't actually sense this volume status. So overall, the kidneys are going to think that we have a low volume status, again, activating the RAS system. Because in heart failure, we have a problem with retention of volume in the heart, thus less of it gets to the kidneys. Similarly, in cirrhosis, we have a variety of things going on, including congestion in the liver, but we also have a massive release of molecules that cause vasodilation in the system. If we get vasodilation, particularly in the venous system, we can get blood pooling throughout the body. So then again, if blood does not make its way back to the heart, less of it actually gets pumped out, and less of it is ultimately sensed by the kidney itself. So first one that we have to consider are hypotensive episodes. In a similar mechanism, we have hypovolemia. And so this is anytime a patient does have a true decrease in their volume status. So this deals a little bit more with the decreased effective circulating volume versus heart failure, or cirrhosis deals a little bit more with the decreased cardiac output. Again, these are both causes that can lead to a pre-renal acute kidney injury. For hypovolemia, the classic ones we want you to think about are sweating. So if a patient sweats a whole bunch, we talked about a previous example where a patient would run a marathon, they didn't replenish their fluids, that can lead to an acute kidney injury. Other ways we can lose a lot of fluids include diarrhea, hemorrhaging, in which we lose a lot of blood products, and vomiting. Another key one that they like you to know are patients who have burns. So these are all a variety of different ways in which we can have a true low volume state in the body. So we can either have a true low volume state in the body, or we can have what appears to be a low volume state in the body with hypotensive episodes. Both of these lead to the same effect, and then we get decreased renal blood flow and GFR, leading to the rest of this cascade. Now, another key one is renal artery stenosis. And in renal artery stenosis, we are again having a mechanism by which less fluid or less blood is actually reaching the kidneys. So if we think about this being the normal vessel, we can see that blood flows through here uninterrupted, ultimately making its way to the kidney to be filtered at the glomerulus. However, in a stenotic vessel, you can see and you can appreciate there's an obstruction here. So if we have blood coming in, we can ultimately get less of it reaching the kidney, or we can decrease renal blood flow because there's a bit of a blockage. There's a bit of an obstruction. This obstruction leads to an overall decreased sensation of fluid in the kidneys, which leads to our same cascade, activation of the RAS system, and ultimately a prerenal acute kidney injury. Now, the last key one I want to mention here are that of medication. This is a very commonly tested one as well. So the key ones that I want you to know about are first diuretics. I think this one makes the most intuitive sense. So a diuretic is meant to offload fluid from the body. If a patient loses too much fluid, we can then create a state of hypovolemia, which can lead to a prerenal acute kidney injury. Now, the two medications I want to talk about the pathophysiology for include that of NSAIDs and ACE inhibitors. So first we'll start talking about NSAIDs. So remember, what is the pathophysiology of NSAIDs, and how might this lead to a decreased perfusion of the kidney? That's right. The pathophysiology of NSAIDs are that they block prostaglandins. We want to block the inflammatory response and hopefully decrease the patient's pain. So with giving a patient NSAIDs, the effect on the kidney is that we get afferent arterial vasoconstriction, and this is going to lead to a decrease in renal blood flow. Just as a quick reminder, there are two key arterioles that we need to know when we talk about the glomerulus. There's the one that goes into the glomerulus, which is called the afferent arteriole. We use the A to remember for A as arrives, and the efferent arteriole is the one that exits the glomerulus. So essentially the blood flow will come in from the body through the renal artery into the glomerulus. It'll have some of it be filtered, and the rest of it will leave out through the efferent arteriole. Now, imagine that we get constriction of this afferent arteriole, so we make it more narrow. So if we constrict this vessel, right, it should make sense to you that a smaller area, a smaller lumen to get into the kidney is going to decrease the amount of blood that can actually get in there. Think about it, right? If we opened a pipe that was pretty wide, we can let a whole bunch of water run through it pretty quickly. But if that pipe is more narrow, now less fluid can actually get through it within a given time. Same thing applies here in the kidney. If we constrict afferent arteriole, if we make it a smaller area for blood to get through, overall, for a given period of time, we have less blood that can make it to the kidney. This is what is called a decrease in the renal blood flow. Now, with ACE inhibitors, we ultimately get a similar effect, but through a different mechanism. So now we're getting efferent arterial vasodilation, which leads to a decreased GFR. So if we look at our example over here, right, we have our efferent and our afferent arterioles. If we now say that we are going to widen the efferent arterioles, we create less pressure in the glomerulus itself to cause blood to run through it, or blood to be filtered at the glomerulus. So the question is, why does dilation of the efferent arteriole cause more blood to not get filtered and more of it to kind of leave rapidly through the kidney, ultimately decreasing the GFR? The way I like to think about this is, let's say there is a launch of the biggest, best TV in the whole wide world going on tomorrow. Everybody waits outside all night for their chance to get the opportunity, and there's 2 doors to get into the store. If both of these doors are of equal size, people will go in at roughly equal rates. So this can be compared to, let's say, being filtered in the kidney versus leaving through the efferent arteriole. You're going to get kind of a mixture of things that are filtered versus what's leaving in the efferent arteriole. However, what if one of these doors is twice as big as the other? Or in our case with the kidneys, what if we dilate the efferent arteriole? What if we make the ability to leave the glomerulus a lot easier because there's a wider vessel to go through? Well, what's going to happen there? Well, now some people are still going to go through that door that's abnormal size, but the door that's twice as large, in this case the efferent arteriole, is so much easier to get through, it's going to send more people through, or it's going to send more blood through, right? If they're rushing to get to the TV, many more people are going to make their way through that efferent arteriole because it's wider and allows more of them to get through. Similarly, in the blood system or in the kidneys, if that efferent arteriole is dilated, if it's wider, that's going to decrease the pressure that's occurring in Bowman's capsule. Less of it is actually going to get filtered, and more of it's going to come in through the afferent arteriole and ultimately leave through the efferent arteriole because it's such a wide vessel and it has the ability to do so. So these are important pathophysiologic mechanisms to keep in mind. Again, both of these are going to lead to what? It's going to lead to a decrease in renal blood flow and or a decrease in the GFR. Again, starting us on this cascade of RAS activation and giving us our classic presenting findings of low urinary sodium and water. So next, I want to move on to diagnostics, and this is super important for acute kidney injuries. We'll do a summary video at the end with a nice table that's going to compare and contrast all the different types, but I want to talk about them in depth here and really explain why these certain diagnostic labs are occurring. And my hope is that these will actually make sense to you intuitively, so you don't have to necessarily remember all of the numbers, but you can think about what the process is that's going on. What's the pathophysiology, and what pathophysiology would lead to these labs. So first, we're going to start off with the urine osmolality. The urine osmolality in a prerenal AKI is typically going to be greater than 500. And the reason is that if we draw our attention over to the tubule, right, we said that we get a release of aldosterone from activation of the RAS system. This is going to bring back sodium and water. If we bring back these molecules, we're going to have a higher urinary concentration because we're sucking back the water. There's tons of different electrolytes and molecules that are filtered in the kidney. Sodium is one of them, but if sodium comes back, the water is definitely going to follow. If we suck a bunch of water out of the tubules, there's still a lot of other molecules that will exist in there that creates a concentrated state. And so that is why we would see an elevated urine osmolality in a prerenal acute kidney injury. Next, we're going to talk about the urinary sodium. And again, I want this one to make sense intuitively. So we're saying that the urinary sodium ends up being less than 20. And this is basically saying that there is a low urinary sodium. We already talked about why this occurs. Activation of the RAS system pulls sodium out of the tubules, leading to low levels. So this makes sense to us that we would expect a low level for a patient that has a prerenal AKI. Again, this is really important because we will compare this to some of our other causes, such as an intrinsic renal AKI, in which we would expect to see a higher or an elevated urinary sodium greater than 40. The reason for that is because when you have an intrinsic problem, which we'll talk about in the next video, you actually have a damaged ability to reabsorb sodium altogether. In a similar way, it should make sense to us that we have less than 1% for what's called a FeNA. So a FeNA stands for a fractional excretion of sodium. It's saying about what percent of our sodium is actually excreted from the body relative to what is actually filtered at the glomerulus itself. We said most of it is actually reabsorbed. So we're not excreting very much from the body. So less than 1% indicates not much of the sodium is leaving the body. And that makes sense to us again, because we know that we are reabsorbing most of it. If it's filtered at the glomerulus and it makes its way down to the tubule, we're still going to bring it back into the body before it ever leaves. So a FeNA, or a fractional excretion less than 1%, is indicative of a prerenal acute kidney injury. Again, we will use this compare and contrast because in an intrinsic renal, we actually have a greater than 2% or even greater than 3% fractional excretion of sodium for a similar reason that I just mentioned, and that in those types of injuries, the kidney is unable to actually reabsorb the sodium. So stay tuned for that in the next video. The next lab we want to look at is our serum BUN to creatinine ratio. And we're saying that the level is going to be greater than 20. The BUN to creatinine ratio is a measure of the concentration of blood urea nitrogen, which is BUN, to the serum creatinine concentration. This is an important measurement because it gives us an idea of what type of kidney injury we are developing. A ratio of greater than 20 to 1 indicates a hypoperfusion injury or a hypotensive injury, indicative of prerenal acute kidney injury. The reason this occurs in prerenal acute kidney injury is because when the body senses low volume status, it's going to bring back molecules that will also bring back water with it. So we said that bringing back sodium is tied to bringing back water, but it's also tied to bringing back another molecule, which is urea. So this increased reabsorption of urea is what leads to the increased BUN to creatinine ratio. So those are the key diagnostic labs that we want to look at. There are some other things we might expect to find in a prerenal acute kidney injury. These include things like an increase in serum creatinine greater than 50% of the baseline and a decreased urine output. Again, an increase in creatinine indicates that we have a problem with filtering creatinine from the body. Typically, we say a normal level is around 1, although this can change on a patient's muscle mass, which we talked about in the previous video. But when we start to see massive changes, if it goes from 1.0 to 1.5 the next day, this is indicative of impaired filtration at the glomerulus and likely damage to the kidney itself. Damage to the kidney can ultimately change our urinary output, and in this case, it can lead to a decreased urine output, specifically if we are dealing with these hypovolemic or hypotensive states. And finally, the last thing I think that's important to note here is that in patients who have AKIs, you can get a variety of different workups, including a urine sediment, but for the most part, they have what's called a bland urine sediment. We're not seeing any spread blood cells, we're not seeing many proteins, and only rarely would you see hyaline cast in the urine. So really, we want to focus our attention on kind of being familiar with these numbers so that we can compare the urinary studies and say, okay, this patient likely has a kidney injury because we see elevated creatinine ratios, they might be having some presenting signs. What type do they have? Well, if we look at our diagnostic labs, we can determine, is this more consistent with a pre-renal presentation, an intrarenal presentation, or a post-renal presentation? The final thing I want to mention here is a specific subset of patients in which the FeNA, or the fractional excretion of urea, is not going to be very accurate for us. And that is for patients who are on diuretics. So the sodium, or the fractional excretion of sodium, is not useful for a patient who is on a diuretic. It's not useful for determining if they have an acute kidney injury. And the reason is because the primary mechanism of diuretics is to keep more sodium in the urine. So potentially the patient does have a prerenal AKI, they're trying to suck out urine, but our labs are not consistent with that because they're also taking a confounding medication that keeps more sodium in the urine in an attempt to offload fluid. So what do? Well, another test we can do is to look at another molecule that's reabsorbed in a similar fashion during a prerenal AKI, and that is the molecule of urea. And this is why it's important that we remember this. When sodium is reabsorbed, it pulls back in water, which pulls back in urea. So all of these things kind of go together. So in patients who are concerned about a prerenal AKI who are on diuretics, you need to get what's called an FE, or a fractional excretion of urea. And this can help you with distinguishing between the various types of AKIs. Finally, I want to move on to management options here. And our management options are going to include things like restoring renal perfusion, right? If a patient has an AKI because they're low on fluids, they're hypotensive, they're hypovolemic, well, giving those fluids back can help increase perfusion to the kidneys with the ultimate goal of improving their symptoms. So these include things like IV fluids or potentially blood if they're dealing with hemorrhage, which is ultimately causing their hypovolemic state. We also want to consider discontinuing medications which are problematic for the kidneys. Sometimes we call these nephrotoxic medications, right? So discontinuing things that are exacerbating the problem, such as NSAIDs, ACE inhibitors, angiotensin receptor blockers, can actually help improve the patient's symptoms as well. We talked about the pathophysiology, about how these can actually decrease blood flow to the kidney, decrease GFR. So if we step back on those, if we remove those from the patient's medication list, we can potentially increase the kidney's perfusion to help it recover from its kidney injury. I also want to mention a couple special scenarios. So there are two conditions primarily called hepatorenal and cardiorenal syndrome, in which administration of fluids would not be helpful. Hepatorenal syndrome is essentially the deterioration of the kidneys in patients who have advanced liver problems or liver disease. And likewise, cardiorenal syndrome is patients who have advanced cardiac problems, such as CHF, can actually then develop renal problems as well because they're not well perfused. But the thing is, if you were to give them fluids, you're not going to improve their symptoms. And the reason is because there's a problem with getting the fluids to the kidneys itself. For example, a patient with advanced liver disease, if they have systemic vasodilation, which results in fluid pooling everywhere or blood pooling in the extremities, giving more of that fluid is not going to get more of it to the kidney necessarily. It's just going to create more pooling in the body. So this is good to be mindful of because they can present this to you in a couple different ways, right? They can either ask for what kind of treatment option would you use in these patients. If it was a true prerenal AKI without one of these hepatorenal or cardiorenal syndromes, then fluids would be appropriate. If it was one of these conditions, they would not be appropriate. Or they can present it as a patient who is presenting with a prerenal AKI picture. However, they are given fluids and their symptoms do not improve. Well, they likely do not improve because they have one of these types of conditions going on. So you might have to do some additional treatments or additional management to help these patients and actually improve their symptoms. So just as a quick overview of the key points in this video, we're talking about prerenal AKI here. Pre meaning before the kidneys. This is typically due to a decreased volume sensation by the kidneys. This can be due to hypotension or hypovolemia, renal artery stenosis, or medication effects that decrease the blood flow to the kidneys themselves. When we consider that a patient might have a prerenal AKI, we want to get some diagnostic labs. And the key things we're going to be looking for are an increased urine osmolality because they should be sucking out water from the tubules, as well as low sodium volumes in the tubules, right? Because we know that we're activating the RAS system and decreasing our urinary sodium. This is what leads us to a urinary sodium of less than 20 milliequivalents per liter, and a FeNA, our fractional excretion of sodium, of less than 1%. Additionally, in a patient on a diuretic, this lab would be less useful because we know that we have a conflicting medication putting more sodium into the tubules. In that case, we would use something called the FE urea. We also see an elevated serum BUN to creatinine ratio because we're bringing back the urea in addition to the sodium in the water, and this is why the ratio would increase in the body. When we see significantly elevated levels of creatinine, we want to be mindful of kidney injuries. However, when we talk about management, we obviously want to replenish fluids if a patient is dealing with hypotension or hypovolemia, or discontinue medications that might be contributing to the patient's condition. But there are a couple special times in which fluid resuscitation is not going to be useful, and these include hepatorenal and cardiorenal syndrome. So I hope that kind of makes sense. Really, a classic presentation that they're going to give you on the exam is going to be a patient who has experienced some type of volume loss, right? They could have been sweating from a marathon, they could have been in a car accident and lost a lot of blood, or they could have just returned from a trip and they've had very significant diarrhea for 2 weeks. All of these things are going to decrease the fluid status of a patient and ultimately lead to kidney injury. They give you these classic presentations and then they show you some of these labs, and your job is to reason out what is their likely type of acute kidney injury. When we see patients who have had inciting incidents that leads to low volume levels, the first one I want you to think about is a prerenal AKI, as this is the most likely cause.